It's a convenience for the patient to be able to have the testing done non-fasting. Again, our standard is fasting, and there's nothing wrong with fasting. You know, I'm a lipidologist. I do a lot of my testing, maybe most of my testing, fasting. But for the primary care doctor, for somebody who's not just focused on lipids per se, it can be very helpful to be able to do a non-fasting draw and then get good lipid panel results. So for the convenience of the physician in terms of not having to order a test later or in advance of the visit, for the patient in terms of not having to fast until 3 or 4 in the afternoon if that's when the draw is going to take place. It is a major step forward, I think, in terms of convenience to get accurate results with a non-fasting sample. You know, the advantages for payers are, I think, more indirect in the sense that maybe there's going to be less redundant lipid testing. Maybe we're going to have a better ability to calibrate our treatment. Certainly, LDL being our primary target of treatment, we really are having a renaissance, I think, of LDL cholesterol goals in the U.S. It is helpful to the payer to have the doctor understand what is the best estimate of the LDL cholesterol, and therefore treatment with various pharmaceutical agents and also, of course, diet and lifestyle can be better focused where it needs to be focused. If we have a better understanding of how low that patient's LDL cholesterol truly is, then I think it's easier to either use the treatments that are necessary or not use the treatments that may not be necessary. So there is a benefit to the payer for sure, not only a modest benefit in terms of the testing, but also a benefit in terms of the use of the pharmaceuticals.